Hey everyone, my name is Dr. Susan Kafle, and continuing on our series on localizing the strokes, I'm back with my fifth video. Today we'll be discussing about the different strokes involving the uh, middle cerebral artery. So let's begin. In this video I'll be discussing about the MCA stroke and the lenticulostriate artery stroke. So this picture shows the blood supply of different areas of the brain. Uh, as you can see over here, the part that is highlighted in red, this is the area that is supplied by the middle cerebral artery. The anterior cerebral artery supplies a strip of the medial side, which is highlighted in yellow, and the posterior cerebral artery supplies mainly the occipital and the inferior temporal region, as highlighted in blue over here. If we cut the brain into two halves and see the inside of the brain, ACA will be supplying the inside part, most of the inside part, and on the back we have the supply from the posterior cerebral artery. So as the circle of Willis ascends upwards into the brain from the brainstem, we can see that it is terminating at the level of the midbrain over here, and then we have this internal carotid artery giving off branches that include the anterior cerebral artery that is ascending upwards towards the medial side of the brain, and the middle cerebral artery is going laterally. At this junction of the anterior cerebral and the middle cerebral arteries, we have the lenticulostriate arteries which supply the internal capsule. If we see on this coronal section of the brain, the middle cerebral artery will be supplying this area of the brain, whereas anterior cerebral artery supplies this medial side. Alright, so like I said, the circle of Willis, it ascends upwards through the brainstem into the cortex, not cortex but the cerebrum. It ends at the level of the basilar artery, ends at the level of the midbrain, and then we have the internal carotid artery giving off branches. This is the anterior cerebral artery, this is the middle cerebral artery. At this junction we have the lenticulostriate arteries. So basically the middle cerebral artery is supplying this lateral portion of the brain, and therefore in this portion we have the fibers descending or ascending. Descending to mainly the upper limbs and the face, and ascending from the upper limbs of the face. Ascending fibers would be the sensory fibers, the descending fibers would be the motor fibers. So we basically have contralateral paralysis and the sensory loss, and then because of the involvement of the facial nerve, upper motor neuron, we have dysarthria, and then we also have involvement of the eye. There will be contralateral homonymous hemianopia as the fibers are crossing over here, and then there will be gaze preference to the ipsilateral side for a day or two, because in a day or two the ipsilateral preference for the gaze will be balanced, and then we'll have some cortical signs. If the non-dominant hemisphere is involved, so non-dominant hemisphere most of the times in a right-handed person is the right cerebral hemisphere. So if we have the involvement of the non-dominant hemisphere, there will be constructional apraxia, anosognosia, and neglect. And because of the involvement of the dominant hemisphere, that would be the left side in a right-handed person, there will be aphasia. We can remember this with this mnemonic that I've mentioned at the top: highly defensive PSG can win. Alright, although I'm not a PSG fan or something, but this mnemonic helps to remember all these manifestations. This photo shows the sensory and the motor homunculus. Homunculus basically means where the different areas of the body are represented in the cerebral cortex. As you see over here, the legs are represented on the medial side, which is supplied by the anterocerebral artery, whereas the upper limbs and the face are represented on the lateral side, supplied by the middle cerebral artery. So in MCA stroke, we basically have the involvement of the upper limbs and the upper limbs and the face. Now let's go through the different manifestations of middle cerebral artery stroke. First, let's discuss the homonymous hemianopia. So if this is an eye and this is the other eye, this would be our left eye and this is the right eye. Now these circles I've drawn for the visual field. So light from the visual field always crosses when reaching the retina. So light is going to cross this way. They travel through the optic nerve, and one of the fibers coming from the lateral side of the retina is going to continue down towards the same side through the optic tract, and the other fiber is going to cross to the other side. So similarly on this side, the lateral part of the retina, the fibers originating from there will continue on the same side, whereas from the medial retina it will cross to the other side. So basically in MCA territory stroke we have the involvement of these optic tracts, because of which if we trace them down, then we'll have the loss of visual field on this side in the left eye and on the right eye on this side. So basically we are having a stroke in this area, so that would be the left MCA stroke, and we have the visual field defect on the right side. So that is why we have contralateral homonymous hemianopia. Homonymous means on the same side, hemianopia means loss of half of the vision. So contralateral homonymous hemianopia means if you have a stroke on the left side, there will be loss of vision on the right side of the visual field. All right. Now let's discuss why there is gaze preference to the ipsilateral side in MCA stroke. So we have a frontal eye field area that is responsible for the saccades, as I mentioned in my previous video. So from the frontal eye field area, we have a descending fiber supplying the paramedian pontine reticular formation in the pons. The pons, the PPRF gives off the fibers to the sixth cranial nerve nuclei, that would be the abducens nerve on the same side, and the abducens nerve would supply the same side, the eyes on the same side. At the same time, the PPRF will also supply the third cranial nerve of the opposite side through these fibers that make up the medial longitudinal fasciculus. Now these fibers, the sixth cranial nerve will supply the lateral rectus of the right side, and then the oculomotor nerve will supply the medial rectus of the opposite eye. Remember the mnemonic LR6SO4. So the sixth cranial nerve is supplying the lateral rectus, fourth is supplying the superior oblique, and all other muscles, extraocular muscles, are supplied by the third cranial nerve. So when left frontal eye field area is being stimulated, we have the gaze towards the right side. So in MCA stroke we have the destruction of this area. So what will happen is the person does not prefer to look towards the contralateral side. That is, if there is left MCA stroke, then the gaze towards the right side would be limited, and the person prefers to look on the left side itself. So there is preference of the gaze to the ipsilateral side, but as I said, this will be only there for 1 or 2 days, and then the brain starts adapting. All right. Now let's discuss the other manifestation of MCA stroke, that would be the construction apraxia. So it is a condition of not having the ability to perform the action of constructing or arranging. This is one of the cortical signs which will be present if the non-dominant hemisphere is involved. And what basically happens is, for example, if you ask a person to draw a cube, which a normal person would draw in this manner, patients would construction apraxia would draw something like this, like they lose the ability of arranging. All right, now the other manifestation, which is also a cortical sign, is anosognosia. So this comes from a Greek word. A means without, nosos means disease, and gnosis means knowledge. So it basically means lack of awareness or denial of their own neurological deficit. Like the person with a stroke may not feel that he or she is having a stroke, or something is wrong with him or her. So this is called anosognosia. Uh, then the neglect is also called the hemispatial neglect. So this is also one of the cortical signs. uh, Neglect basically means the person will fail to attend to or respond to or acknowledge the stimuli on one side of the space. For example, if the person is having a stroke of the right side, the non-dominant side, then the person will neglect the left half of his or her body. So if you ask this person to draw, the clock face with the numbers in it, then he or she might draw something like this, like all the numbers he or she would put in one side of the clock while neglecting the left side, because the stroke is in the right side, so they would neglect the left side of the clock. So this basically is neglect. Finally, let's discuss about the lenticulostriate artery stroke, which would be due to the involvement of these lenticulostriate arteries. Involvement of the lenticulostriate arteries would involve the internal capsule, which is lying over here. So this region is the internal capsule. It basically has three parts. This is the anterior limb, this is the genu, and this is the posterior limb. All of the motor fibers, they are concentrating on the posterior limb of the internal capsule before they descend, and the sensory fibers, as they are ascending, so they are pretty dispersed as they ascend towards the cortex. They don't have a focus like the descending fibers, rather they are dispersed, but they are still present in the posterior limb of the internal capsule. So if the posterior limb is involved, then we'll have a pure motor stroke or a pure sensory stroke, but pure sensory is less common because the fibers are dispersed. So if we have sensory involvement, then we basically will have mixed sensory motor stroke. And if the genu of the internal capsule is involved, this is where the fibers, the corticobulbar fibers, are crossing, so the upper motor neurons of the facial nerve will be involved, and later the stroke will come to the posterior side and start involving the motor and the sensory fibers. So that would give rise to dysarthria because of the facial nerve involvement, and clumsy hand because of the involvement of the the corticospinal fibers or the motor fibers. So these four can be the manifestations of the lenticulostriate artery stroke. So that's it for this video, guys. I hope it helps, and I hope that you know and understand the mechanism behind different manifestations of MCA territory stroke. Thank you. I'll see you in the next video. Bye.